Hi, everyone. Welcome. It is my pleasure to moderate today's discussion. My name is Nikita Boston Fisher. I'm a PhD student in the department working under the supervision of Dr. Elaine Adams and Dr. Kate Rice. I'll first start with our land acknowledgement. McGill University is located on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. McGill honors, recognizes, and respects these nations as the traditional stewards of the lands and waters on which we meet today. It is my pleasure to introduce our speaker today, Machelle Wilchesky. Machelle Wilchesky is an assistant professor within the Department of Family Medicine and Division of Geriatric Medicine at McGill University, and scientist at the Center for Clinical Epidemiology of the Lady Davis Institute for Medical Research. As Director of Research at the Donald Berman Maimonides Centre for Research and Aging, she has established an independent research program that focuses on improving the care provided to vulnerable older adults, many of whom live with dementia, residing in long-term care facilities. As a reminder to everyone today, the presentation will be roughly 30 minutes, leaving 25 minutes for discussion, and our seminar will be recorded. If you would not like to be in the recording, please turn off your camera. Questions from the audience can be posted in the chat, or you can raise your hands. Dr. Wilchesky, over to you.
Thank you so much. Okay, so my talk today is called Conducting Primary Care Research within the Geriatric Long-Term Care Setting. And today, the organization is, I'm first going to try to give you context about dementia and long-term care. Although there are some of you who actually work in dementia, not all of you are very familiar with long-term care, what it is and what that setting is about. And then today I'll talk about opportunities and challenges with respect to conducting research in this environment. So that was the Time magazine cover, Baby Boomers Turn 40. Can somebody try to put in the chat, try to tell me what year they think that was? Does anybody have an inkling of when that might have been? Yes, anybody? Okay, so I'm going to give you a hint. Oh, anyway, so it was in 1986. So in 1986, the baby boomers turned 40, and these baby boomers have always had an outsized presence compared to other generations. They actually peaked, they're no longer the biggest, they peaked at almost 80 million in 1999, and they remained the largest living adult generation until that time. We just recently had a Canadian census, so this is kind of hot off the press. It was released last April. And in terms of the Canadian population, aged 85 plus, that population doubled, actually more than doubled from the 2001 census. It's the fastest growing age group. There was a 12% increase from 2016. It currently comprises 2.3% of the population. COVID-19 did claim many lives, unfortunately, among the oldest Canadians. However, this population continues to grow rapidly. And over the next 25 years, they expect this population to triple to almost 2.5 million in Canada. There are also 9,500 centenarians living in Canada. So adding years to life, it's a great thing. It's a wonderful thing. Modern medicine, antibiotics, we're not dying at 40 anymore. However, it's only an excellent achievement if you don't have challenges. And unfortunately, some challenges are age-related. And as functional independence goes down, your dependency on others obviously goes up. And support for older people who lose independence through disability, illness, and age-related frailty takes many forms, ranging from family-based community models to long-term care within institutions and hospitals and nursing homes. And our own census actually points to this. A significant portion of our Canadians age 85 and older, more than a quarter live in collective dwellings, such as the nursing care facility. You know, and as more seniors reach 85 and beyond, you know, an increasing number will face limitations and will require long-term care. So this is you know, a situation, our population pyramid, as it were, where we are and where we're going. This is something we have to think about. So now I'm going to jump to dementia and Alzheimer's disease. So, you know, so Alzheimer's disease is a form of dementia. It's the most prevalent type. It currently represents about 60% or accounts for 60% of dementias in Canada. It's kind of a brain cell degeneration, which ends up resulting in deterioration in thinking ability and memory. So it's cognitive impairments. And it can also affect behaviors, mood, emotions, and the ability to perform everyday activities. The onset is most often gradual, but it ends up causing significant impairment in social occupational function. So in the very recent landmark study by the Alzheimer's Society of Canada shows this to be the latest estimates for number of people with dementia by type, comparing 2020 to what they expect in 2050. And we see that, Alzheimer's dementia continues to be the dominant type of dementia in Canada in the coming decades, with over 1.1 million people affected by 2050. So there's Alzheimer's, which is the biggest form. Vascular dementia usually is the second biggest form. And by the way, this is pretty representative of the world. I mean, I'm not going to show you every country and WHO, but we're pretty much on par with the globe. Other dementias and mixed dementias account for another part. So this is an older study. This was conducted by Howard Turco in 2008. Howard was at McGill until recently. But many of these dementias overlap and are comprised of, that's what we call comprised of mixed types, because many people live with multiple forms of dementia that coexist or concomitant. With dementia, increased severity, unfortunately, comes increased burden and increased level of loss of abilities. So this is the Risberg scale, or it's a representation of it, where in stage 1, you appear normal, even with very mild dementia. I mean, if you were tested and you tested positive for mild dementia, you probably it wouldn't be noticeable to family and friends. Stage 3, maybe you're noticing your loved one is forgetful. Stage 4, family and friends start noticing problems. And then, we start moving into the more severe and terminal stages, where at the end, if you live that long with dementia, if something else doesn't kill you first, basically, you would end up probably losing speech, locomotion, consciousness, and die from dementia. So dying from dementia, dying from Alzheimer's disease. Yes, Alzheimer's is a terminal illness. And this is an old slide that I used to show. This was from 2000 and, sorry, I can't see it somewhere, 2014, sorry, where Alzheimer's disease was ranked 7th in Canada as a leading cause of death, after diabetes. I've updated the slide. So this is the update. So if we look at 2019 and 20, and I show both of them because COVID did sneak in there. So in 2019, which was the last year before COVID happened, it had fallen to 8th rank. And then it fell to 9th rank because COVID all of a sudden hit and became number 3 for reasons Canadians died. But Alzheimer's disease continues over this decade as being a very significant top 10 reason for death in Canada. This is one showing the projected prevalence of all the dementias. Anyway, I don't want to belabor the dementia with too much. I think the most important point to think about is that the estimated growth number of people with dementia is going to be huge as our population ages, as that 85 plus population triples in number, or expected triple. This is what we think is going to happen with dementia. And with dementia comes a population that needs more. They need more services. They need more care. So this is our segue into CHSLD. CHSLD is a Quebec acronym, at least I believe it's just Quebec. I don't know if it's in France, but I believe it's a Quebec acronym. It stands for Centre d'hébergement et soins de longue durée. It's also called nursing homes in the United States. Canada, the rest of Canada calls them long-term care centers, LTC. Depending on where you live in the world, there are different terms. Aged care facilities, residential care. It's even called hospice in some parts of the world, which was interesting to me because I associate hospice with cancer and AIDS. But anyhow, what we're talking about are residential facilities that provide 24-hour professional nursing care and supervision in a protective, supportive environment for people who have complex care needs and can no longer be cared for themselves in their own homes. In Quebec, there is a somewhat complicated government process for admission to long-term care. It always starts with your local CLSC and being evaluated on something that is a Quebec invention called an ISOSMAF. But in any case, what they do is they evaluate you or your loved one, and they indicate where your deficits are, and depending on the types and degrees of severity of those deficits, you are given a profile number. And if you have a profile that is greater than 10 and there are only 14, then you are eligible for long-term care, CHSLD care in Quebec, because you are, that means you require more than 3 hours of care per day. And that is the Quebec cutoff. If you require more than 3 hours for care per day, you have access to CHSLD. You can be placed in the CHSLD center. Other eligibility requirements is you have to be an adult. So only adults are admitted, obviously Quebec resident with diminished autonomy. What do CHSLDs provide? Well, first and foremost, they provide primary medical care. The doctors who provide care in the CHSLD setting are primary care doctors, for the most part, almost exclusively. Also nursing care. It is a nursing home. The majority of the daily care that is given, of course, is nursing care. Doctors don't give daily care, but they give the medical care. They provide accommodation, assistance, support, supervision, psychosocial services, pharmacy and rehab services. And by rehab, I mean physiotherapy, occupational therapy, and recreation therapy. And sometimes specialty care. Where I am from at Maimonides, we have dermatologists and ophthalmologists, and we have specialty physicians who come in and give clinics at our site, but that's not the norm. This is a very recent report that was put out by the Quebec Ministry of Health, just to give you an idea about what the length of stay is for a resident in long-term care. And 823 days, that represents 2 years and 3 months. So the average length of stay for a resident in long-term care is 2.25 years. And just so we're clear, this is not a rehabilitation center. People do not then go on to something else. They might change centers if they're very unhappy with where they are. That's possible. But individuals who end up in long-term care usually end their life in long-term care while they are residents in long-term care. Maybe it's possible sometimes they end up, unfortunately, dying in hospitals, which is a whole other situation, but they are residents in long-term care. This is the portrait of long-term care homes in Canada. So currently there are 2,076 across Canada. We see that Quebec has 440. This number might seem big to you. I can assure you it is not. Our country is plagued with long-term care bed shortages and huge waiting lists. And the situation for long-term care is not a good one. This was a comic that was published in 2021. The pandemic highlighted the situation that had been persisting for decades. This is just a snapshot of some articles that came out. But the prevailing message was this sector of the healthcare sector is underfunded, it's under-resourced, it's understaffed, and it has been for a long, long time. Having said that, yes, recently there was a big announcement in the province of Ontario where they got $379 million, which was going to help them support for retention measures of staff, and give them more PPE and support for strengthened infection control, what have you. But to date, as far as I'm aware, this is the only big announcement that has been made, and it was in Ontario. Okay, so that's the context, just to give you an idea about what the care setting that I am discussing. So now let's talk a little bit about opportunities. And to do that, what I'd like to do is I'd like to start off by telling you a true story about a CHSLD quality improvement project that went wrong. So early on in my days as being the director of research at Maimonides, and back then it was just Maimonides and Jewish Elder Care, which is our sister site. It was before Bill 10, before we became a network, CIUS, with 7 sites. But back then, it was just Maimonides and Elder Care, and I was invited in my capacity to participate in all of the nursing management meetings that were monthly, as well as the medical meetings. And we're going to talk a minute about pressure ulcers. I'm going to get back to the meetings in a second. So what are pressure ulcers? Probably most of you know, these are localized injuries to the skin and underlying tissue. It's usually due to pressure or in combination with shear and friction. Pressure ulcers, they're a quality indicator across multitude of healthcare settings, not in least of which long-term care. Pressure ulcer rates is always looked at when looking at the quality of a long-term care home. The pressure ulcer prevalence estimates, they vary across countries. Really it depends on the target population, depends on the healthcare setting. But the thing you have to remember is that this pressure ulcers are a very important indicator, because they're associated with high mortality and morbidity, healthcare costs, and increased patient suffering. So just to give you an idea, and this isn't the most recent data in the world, and I apologize for that, but the reason why I'm showing you this slide and not a different one is because I liked how it gave you, the context of different care settings. So if we're talking about acute care and looking at prevalences, we see that it ranges from, so Newfoundland always comes out very low, good for Newfoundland, but other than Newfoundland, you see can range from 26% to 34%, I mean, 27%, 29%, it's up there. In community care, it could be as high as 24%. That was a study in British Columbia. And in non-acute care, most of which is long-term care, we see there's a huge range. I mean, it goes all the way up to 53%, I think is the highest here. So very wide range of prevalences. Now, where I was coming from was the Donald Berman Maimonides Geriatric Centre. So that is where my dry lab is located on site on the 2nd floor. It's the largest CHSLD in Quebec. I found that out today because the one that was bigger than us, they had to close 90 beds recently. So now we're the biggest. So it's 387 beds, which is actually huge. The building is divided into different floors. Every floor represents a different care population, where we have regular just dementia residents. Then we have a floor for dementia residents with behavioral problems. We have a dementia floor for adults who had psychiatric comorbidities, who then, by the way, became old and now have dementia superimposed on major psychiatric comorbidity, and we also, etc. So at Maimonides, this is not really up to date, but it's fairly accurate. At the day that I took the snapshot, the age range of our residents was from 35 to 104. So it's not all old people. I mean, some folks are younger. They have had catastrophic strokes. They have Parkinson's disease, other reasons why they are no longer independent and require more than 3 hours of care per day. We have 25 residents who are over 100 years old. The average age is 86. 64% female, not surprising, because as we get older, females seem to outlive males. And at that time, our average length of stay was 3.4 years, which is actually higher than the average. And that's a function also of the fact that we have a big floor of younger residents. So you can imagine the distribution of ages. We have a long We have a tail to the left of this floor of younger residents, and they contribute to the average, which of course some of those residents stay for 30 years and 25 years, and then you have the regular ones who, the older residents, dementia residents, who end up staying for about 2 years. Dementia, it's about 85% of our population, and depression and anxiety are in the charts of about a quarter of them. So back to my meetings. So I was, I would attend and participate in these meetings. And at the time, Lucy Tremblay, who you might know, she is now a director at the CHS. Before that, she was the president of the Order of Quebec Nurses. But she was at the time, director of nursing at Maimonides and Elder Care. And she had a dream. She had come off a wildly successful intervention program to reduce the restraint use, so the use of restraints in long-term care, to 0 at Maimonides. And her dream was to get pressure ulcer rates to 0 at Maimonides and Elder Care. That's what she wanted to do. If we look at what she was dealing with, she established this big wound care project in the building and at Elder Care to reduce pressure ulcers, but her baseline was 8%, which, as you will remember, is quite good, right? You saw what the range was. 8% is really on the low side. So she was starting with 8%, and her dream was to get 8 down to 0. And how was she going to do this? Well, she implemented a big project using the Braden scale. So the Braden scale is the scale. It's a scale that's recommended by the National Pressure Ulcers Advisory Panel. It's the most frequently used risk assessment tool in North America. It is the tool that is recommended by the M3S here in Quebec and by the Order of Nurses. It's a predictive risk assessment scale. It basically works looking at evaluating these domains, so sensory perception, moisture, activity, mobility, nutrition, and friction and shear. And these are all evaluated, and then you come up with the total score, and the lower the score, the higher the risk you have of developing a pressure ulcers, and usually the cutoff value that's often used is 18. And given different scores in different domains, there are interventions that can be implemented on a nursing level to ensure that residents don't either develop or that their small pressure ulcers don't increase in stage and severity. So if we look at the distribution of pressure ulcers that were discovered at baseline from that study, we see that where did the majority of them happen? Well, you see toes, so heels and toes. And you can imagine, if you can think about an 85-year-old who is not in a wheelchair. So yeah, they're shuffling their feet along the floor, and that causes a lot of friction on their feet and their toes. And they're sitting a lot, which is why these bars are high as well. But this is where the areas of pressure ulcer happen in this population. So would somebody like to guess what happened when Lucy Tremblay, the director of nursing, spent a year and a half putting all of her resources into the let's get pressure ulcers down to 0 basket? And remember, this is tough, because she, if you're going to target that means you're not targeting something else. That means you have resources that I already explained to you are very, yes, Marion. And if you already know the answer,
you kind of just gave us the answer, but I was going to say, if you put all your resources into preventing pressure ulcers, other variables or outcomes for the elderly population are going to get worse. So maybe they had to increase use of restraints or increase other less optimal interventions with these residents.
That's an excellent observation, but that wasn't the question I was asking. I was asking what happened exactly just to pressure ulcers.
Oh,
although you're right, Marion. Right.
So I'm guessing that they got worse, because otherwise you wouldn't be asking this question.
That's right. They got worse. So she spent all these resources and they got worse. And oh my God, was she upset. She was frustrated. I mean, she felt terrible and she didn't know what to do. So, begs the question, is the Braden scale valid within the long-term care setting? So I received the data, and we looked at the data, and in our sample, it's not that our teams that our clinicians were doing the wrong things. They were calculating it correctly. They were putting in all of the implementation, the nursing plans as appropriate, and it wasn't helping. It wasn't doing anything. So we conducted this study looking at the predictive and current validity of the Braden scale in long-term care. And I won't bore you with the details, but these two green bars represent the validity studies done, the original ones done by Braden and Bergstrom. So the first Braden validity study was conducted in 2 acute care units. Okay, so general surgical ward and general medicine wards in acute care. And it was found to have the highest predictive validity using a product score of 16, and the scale had 100% sensitivity, guys, 100% in both samples, indicating that all patients who eventually developed a pressure ulcer had a Braden score of 16 or less at the time of their risk assessment. Now, specificity did vary a little bit, but sensitivity was 100%. So what did we find? Whoops, that's not what I wanted to do. Oh. I'm sorry, my hold on, sorry, my apology. I'm going to take that off right now. That was supposed to be an animation. That square was supposed to animate and come off. I'm going to stop share. I'm going to reshare right now. Apology. Are you seeing the right screen or my screen?
We're not seeing anything yet.
Oh. Sorry. Okay.
It's there, but not in presentation mode. Yeah, exactly.
Yeah, there we go. Okay. So this is what we saw. So these green squares, that was the original studies, which of course, that's why the Braden scale was used. And it's used appropriately in long-term care. But when you look at long-term care, when you look at the samples in long-term care, well, guess what? Sensitivity isn't 100% anymore. Maybe you're getting some specificity in these predictive samples, but anyway, it's the moral of the story is that it really wasn't surprising. The appropriateness of the scale is questionable given its low specificity in particular and low positive predictive value. And the moral and valuable lesson of the study is that, and of the story, is that you really have to validate the tools for the population in which you're using it. Long-term care, unfortunately, is a setting that has been using hand-me-down tools forever because there's a lack of research that goes on in this setting. So in 2011, which pretty much coincides very shortly after I became the first full-time director of research at Maimonides to do this kind of work, the International Association of Gerontology and Geriatrics came up with a global call to arms. And they said the paucity of high-quality research conducted in nursing homes has resulted in this recent call to action to improve the quality of care by them. So this is what I live for. This is what I do. This is what my program is built on. So back in 2014, I participated in a research. I helped deliver a research boot camp to this North American nursing home directors group. And the top 10 research topics at the time were everything from care transitions, polypharmacy, non-staff elder abuse, i.e. resident to resident elder abuse, use of technology, et cetera, et cetera. I was very happy to see when I was preparing for this talk that just half a year ago, the American Association of Post-Acute and Long-Term Care Medicine, this is the same society that the American Medical Director Association that puts out JAMDA, which is our premier journal in this kind of research, came up with 3 different domains of outcomes that should be looked at and the kind of topics. Really, it's not much has changed, maybe a little bit more talking about telehealth and technology, but very much the same story. So, I mean, the call to arms remains. A few of the topics that we investigate at my center, and this is just touching the surface: medication use, delirium superimposed on dementia, neuropsychiatric symptoms of dementia. So I know you all at the department, you are very familiar with CCNA Team 19. That's the ROSA team that's led by Isabel and Howard, and I'm a proud member of Team ROSA, but there are many teams at the CCNA, and the team that I'm most involved with is Team 11, which is for the treatment and prevention and treatment of neuropsychiatric symptoms. So we do a lot of work in that space. We also look at interventions to reduce potentially inappropriate transfers to the acute care setting, elder mistreatment, and hot topic recently are wearable sensor technologies, which we're implementing and investigating to detect and monitor neuropsychiatric symptoms, to improve incontinence care management, and to monitor vital signs in residents who are ill, because of course the doctors who are on call. It is potentially useful for them to be able to see this in real time, this data, and be able to look at it when they want to. So let me just talk for a minute about improving CHSLD prescribing. So, I mean, that includes polypharmacy, inappropriate prescribing, and antipsychotic medication use. I won't ask the question, but polypharmacy, I mean, it involves multiple drug classes, usually a cutoff number. I mean, it's sort of artificial, but if somebody is taking more than 5 medication classes, that has been called polypharmacy. I won't ask the question. I will tell you, when I got to Maimonides, the number of medication classes that residents were coming to when they were coming to our institution was 14 different medication classes. And, in some recent studies and collaborations I've been part of with Edeltraud Kroger and others, Edeltraud's an associate member of our department, are between 8 and 12 in Quebec City CHSLD. So polypharmacy remains a problem. It's getting a little bit better because there have been government programs to specifically reduce antipsychotic prescribing, but it remains an issue. But the problem of medication use in long-term care is that, our residents have always been the biggest consumers of drugs. 81 pills per week on average. This was a study done by Arcan. And with all of these concomitant medications come, the higher the risk of potential adverse events, and these residents that we're talking about, the majority of whom are very frail and with limited life expectancy. And when you are frail and with very limited life expectancy, the goals of care theoretically should be shifting from a preventive strategy to a comfort strategy. And so these drugs and the pharmacists and the clinicians working in these centers need to review and adjust and discontinue medications to be able to work within the goals of care of residents and their families, which isn't always an easy thing. Deprescribing is hard in the best of times. It's even harder when you're the daughter and your doctor's saying, you know what, I don't think your mom really needs to take this primary prevention drug anymore. It's hard to listen to. It's hard to hear. But evidence and guidance has been lacking for this specific population, i.e. the population with advanced dementia. So if we look at, this is a Venn diagram that a student I had once put together, and it's a Venn diagram that compares and contrasts the drug classes listed in the Beers, the STOP, and the McLeod criteria. These are 3 different criteria for appropriate prescribing in older adults. And we can see that, there's overlap, certainly. These are the drugs in whom, probably they all agree that they are probably inappropriate and should be stopped. But this pertains to older adults, which are 65 plus. We're not talking about the 85-year-olds with advanced dementia. We're not talking about those folks. This is just general 65-year-olds and older. So, part of what we did, one of my first projects in my program was to work with researchers across Quebec to try to develop an interprofessional intervention comprising of some sort of continuous education tailored tool to optimize medication use. And how did we start that? We started that by doing a Delphi process, a scoping review, and then a Delphi process to come up with trying to classify categories of medications as being appropriate or inappropriate or maybe appropriate for this specific resident population. And I'm running out of time, so I'm going to go quickly, but we did this Delphi panel, which was, geriatricians, GPs, pharmacists, nurses, social workers, ethicists. And the final result was this. This is the how the drugs this is the categories that they reached. So rarely appropriate was this group, generally appropriate was this group, and our panel experts were unable to come to a consensus for this group down here. The thing that's really interesting are the biphosphonates and the lipid-lowering medications. These are drugs that are so prevalent for people who come into long-term care, and you have to remember and I'm talking about the older folks, not the younger folks who come to long-term care. Remember, their average length of stay is 2 years and a quarter. Well, if you are taking biphosphonates and you stop your biphosphonates tomorrow, I mean, the trial evidence shows that your primary prevention against osteoporotic falls and fractures is 7 years. So if you stopped the day you came to long-term care, you're still covered. Same for statins. Statins, it's about 5 years of primary protection. So these people are taking medications. This is a frail older population who, many of whom have dysphagia. They have the difficulty swallowing pills, and these medications are interacting with each other. It's a very big problem. So yes, we produced interventions. We did a pilot study, and then we did a pragmatic trial. There are opportunities here. What's needed for continuing is a controlled cluster randomized trial for sure, because unfortunately, even in our pragmatic trial, the differences in baseline use of inappropriate drugs was too high in the control group, so that it was too low in the control group, such that it was very difficult to show a difference. But that's just an example. So I want to talk to you just very quickly, and I know I'm running out of time, Nikita, with some challenges. So challenge number one is Quebec and the status of data. So this is what a resident chart looks like. It's in multiple volumes. It is huge. It is paper. Quebec does not participate in the continuing care reporting system that all other provinces do. All of the provinces' nursing homes, they use something called Interray, which is an electronic database. It requires homes to perform quarterly evaluations of their residents on a whole set of domains and report them to Ottawa. And then all these provinces and homes can compare themselves and their quality indicators against each other. Quebec doesn't have that. Quebec has been against being part of that since forever. So we are only dealing with the paper chart situation, which is hard because it means you have to invest a lot of resources to get even the basics of data. But I want to point out that this is both a challenge and an opportunity. Because we don't have Interray data, and there are problems with Interray data, there are many people who have many qualms with the assessments and the way they are calculated. This is a challenge. This is an opportunity because we can really get down and dirty with the actual detailed notes, nursing notes, and medical notes, and we can tailor what we want to do and how we want to get that data. It just takes resources, so it means our budgets are higher than most other provinces to be able to do this kind of research. Ethics. So before 2013, conducting research in vulnerable populations in Quebec was really, really hard. It was really tough because the interpretation in Quebec was sort of at odds with the ability to do research. I mean, it was so restrictive and so prohibitive that hardly any research was done. Luckily, this changed in 2013. But there are still recruitment challenges. So consent procedures can be very arduous. Researchers are not allowed to approach either residents or their families directly. You always have to be invited. So, and to do that, you need a member of the staff to get that invitation. So if you're talking about a resident who's apt and who's living in the home, so it means a member of the research staff has to go knock on their door and say, hi, we have a group of researchers and they have a study, and would you be interested? I think you'd really like it. And then only if they say yes, sure, they can come, are we allowed to knock on the door and say hello. Similarly for families, we're not allowed to pick up the phone and call them. We're not allowed to mail them a letter, send them an email. They always have to be contacted by the CHSLD staff. Same thing. There's a study going on. We think your loved one would benefit from it. Can they contact you? So this is tough. This is a hurdle. I'm not going to lie, because we're talking about using scarce CHSLD staff resources, and we already said very scarce, under-resourced. They don't have time to do some of the basic care. Now, on top of that, we're asking them to be champions, these fantastic champions, and to help research teams to be able to get to their, their potential participation populations. So that's tough. So I'm going to talk for just a couple of minutes about my large delirium prevention trial to illustrate some of these challenges. So this was my big prepared cluster randomized trial. The objectives were to compare the effects of our multi-component prepared intervention to that of usual care. Primary objectives were to see if it reduced delirium incidence, severity, episode duration, and frequency, but we also had a whole list of secondary objectives as well. There were a whole huge host of very in-depth clinical evaluations that were going to be conducted to be able to answer our research question. It was planned to be a 4-year cluster randomized intervention. What do I mean by clustering? Most of you know, but in case you don't, it means that the randomization happened at the level of the home, at the CHSLD. So, you either, the whole CHSLD was either in the intervention or the control group. We used some fancy methods to do this. A method that I learned going to one of the NAPCRG conferences. So you should go to NAPCRG, you learn really good things. Follow up for each resident in the study is 18 weeks or until death or transfer. And just to give you an idea, this is what I know I'm speaking quickly. I'm just trying to give you an idea of the scope so you understand where this is all going. This was the spirit diagram. We see, a follow-up of 18 weeks and all these assessments. So my team would go once a week on the same day in the same morning or afternoon of each week. So if Mr. Jones was a participant and he would be seen every Monday morning by a member of my team to do these assessments for 18 weeks to get to collect our data. And this is what our sample size looked like. Now, I'm showing you this because this is an issue. So because it's a cluster randomized trial and because all roads to validating interventions in this population will likely lead to cluster randomized trials because it's the most logical way of, we implement intervention at the level of the institution, not the person. It's very difficult to teach a nurse or a doctor at a facility something and then ask him to forget it for the control residents, right? So it makes much more sense to implement interventions at a site level, and then the whole site has to be randomized. But with that comes some statistical complexity. You have to take into account ICC, the intra-cluster correlation coefficients. Those play a role in terms of determining your sample size. And you can see that for our study, we were looking at needing anywhere from 300 to 600. So we were expecting our ICC to be somewhere around 0.06. And for the hazard ratio, because we're looking at the time to incident delirium, so it's a hazard ratio, time to event, we were looking at sample sizes around here. So that's a big sample size. ICC, it's sort of like the lone bullet in the Russian roulette of research. You don't know what your ICC is actually going to be till you do your study. So you can plan and plan and plan, but if you're wrong and your ICC is all the way up, higher than 0.6, well, you're going to have a problem. So bigger sample sizes. Because of the nature of the kinds of studies we do, that represents a challenge for sure. How are we going to achieve the sample size? Well, we succeeded in partnering with all 5 CIUS across the island of Montreal, plus the semi-private institutions. So that was good. Anyway, I'm not going to go into too more about that, but I want to go back to the protected population and the consent procedures. So, faced with a very big task of recruiting a very large sample size, due to the inclusion of both public and private sites, and, it was a time of turmoil. Bill 10 had just happened. Our REB, a local REB at the Jewish, wasn't quite ready for all of us yet. So after a year of having our protocol, they decided to direct us to the Comité Central d'Éthique de la Recherche, the CCR du M3S. Which actually we were happy about. We wish we had done that to begin with, because this was the big ethics board for all of Quebec, chaired by Serge Gauthier, who, by the way, had been the former chair of McGill IRB. He's a neurologist specializing in dementia. He's also a wonderful human being. I've met him many times. So we were very happy about this. However, their interpretation being able to get to our families, and they were families because an inclusion criterion was that you had to have dementia. Okay, so almost none of our residents were apt and able to consent for themselves. Their interpretation was that nurses would have to have that conversation in person. So yes, ideally, conversations of this kind would happen in person, but unfortunately, family members really usually limit their visits to evenings and weekends, and that's not when the day shift's working, if at all. Many residents don't have family members visiting them, and also the family member who visits is not necessarily the legal representative who is in charge of signing the consent form, right? I mean, that person might be the son who lives in British Columbia or California, and it's the aunt or the cousin or whoever who's the person who's coming to visit and with the person. So I mean that. So problems with ethics continue. It took fighting. I mean, we have a great relationship with them, but it was a challenge to get them to understand why their interpretation was impracticable. And if you don't know this word, this is a word that I learned when this came up. So impracticable, it means making something impossible in practice to do or carry out. And, so in research terms, it means that the additional financial, material, human, organizational, or other resources to obtain consent can impose hardship or burden on the researchers, or maybe become so burdensome that the research can't be done. And that's what would have happened. We would have ended up with, I don't know, a sample size of 20. It would have been impossible. Something to keep in mind when dealing with this population, and this is a slide that we always used in our roadshows when we were trying to promote the study, and this helped us get such collaboration. We recognize the fact that we're collecting a lot of data through one-on-one interactions with vulnerable people. Each member of my team was handpicked as people who actually have a joy and compassion and enjoy working with seniors, and have experience working with understand dementia. We organized it such that we weren't trying to go in and out of the room as quick as possible and do our interventions. We promised institutions and their families that each week that we came to visit, we'd also have a conversation with them and that we would engage them. We would give them some sort of stimulation. So that is both a challenge and an opportunity. I would say it's an opportunity for a win-win, and win-win, I would argue, in any research or care setting is always a good thing. So look, my time is up. The bottom line is this: CHSLD research is a very big topic. There are many challenges, there are many opportunities. I've just really scratched the surface here, and I hope that this presentation has maybe demystified a little bit of what I do, because I know many of you for many years, and many of you maybe until today had no idea what I did. I just want to finish by saying that perhaps the most important opportunity that I didn't say is to contribute to advancing the evidence base and to improve the care for this segment of society that is really most deserving. And I would be remiss if I didn't also give thanks to my 2 department PhD students. So Denise, her topic in this space is reducing potentially avoidable acute care transfers from long-term care homes, developing a taxonomy of interventions and improving approaches to evaluate intervention effectiveness. And then Elena, who came to me as an art therapist, her topic is Art Therapy Interventions to Reduce Neuropsychiatric Symptoms of Dementia towards Establishing Evidence-Based Knowledge Using Objective and Feasible Outcome Measures. I want to, tip my hats to them. Both of them had clinical projects that were canceled due to COVID, and they had to reinvent their projects, but they're doing very well, and I congratulate them. And thank you. That's it.
Thank you very much, Dr. Wilchesky. Are there any questions from the audience?
I just hope this was helpful.
Oh, we have one from Dr. Dove.
Hi.
Thank you, Machelle. This was super interesting. Opened my eyes to a lot of the challenges of doing research in a CHSLD. I guess I have more of a comment than an actual question. So you presented a lot of the data in the beginning about the increasing rates of dementia at the end of life. And I guess I just have a hard time, even though I'm a physician and I'm supposed to know these things, about understanding the difference between normal aging and dementia. And I know it's kind of an arbitrary cutoff